Welcome to the PA Perspective podcast. I'm your host, Mackenzie, and I'm so excited to begin this journey podcasting throughout the medical profession. So welcome to this episode. Today I'm joined with Rochelle. You are a social worker. Have you been practicing for about 20 years?
About 20
right?
years, yeah.
I was doing that math and I'm like, wow, good for you.
It's a
so
long time.
You did your master's of social work first. Then you did your master's of bioethics as well.
That's right.
And now you're currently working on your PhD.
That's right.
Which is insane.
It
Good
is.
for you. Like, the academic achievement right there is insane. I think I'm done after this master's.
I see. That's what I said. So I was like, after my MHSC in bioethics, I said, oh, that's it. I am officially done.
Schooled out.
And I always say I was tricked. I was tricked into doing my PhD. I knew that there was like a particular interest around a specific topic in question.
Right.
And I was just talking to a colleague about it. And, you know, the thought of the PhD came up and I was like, I don't want to do it. Can I do something else? Like, here are my reasons for not. And, you know, it was like step by step. Well, find out about this. And why don't you find out about that? And then by the time I'd gotten all my information, he had said, all that's left is to apply. And I was like, oh, I didn't want to do this. How am I here now? I have to apply. So this feels like a really wild journey for me as well.
But good for you. Like, wow. So let's just start back. I'll let you kind of introduce yourself, but I'll guide it by saying, like, what got you into social work? Like, did you always know that's what you were going to do? And then kind of bridging it into how you became into your PhD now.
Yeah, it's a weird journey. So I did my undergrad in health sciences.
Oh, okay, nice.
And knew I wanted to work in healthcare.
Right.
I secretly wanted to be an orthopedic surgeon.
Oh, wow.
Mostly because people told me I couldn't do it.
Okay.
I was like, I'm going to do it.
I love that.
And in the course of doing that program, I had to take a bioethics course.
Okay.
Which I was really nervous about.
Right.
Because I was like, it was not philosophy. I mean, I was not in philosophy. I was in health sciences, like very concrete, black and white, right and wrong kind of a thing. And got into this, had to do this ethics course and was loved living in the gray.
Okay.
Loved talking about case-based type of things. Loved talking about, well, from this angle, from that angle, how are we thinking about it? And the first course I took, I was like, was that a fluke? Did I were the conditions right for this? Took another course. It was more challenging.
Right.
It was a fourth-year course by then. Loved it all the same. Knew it was challenging, but didn't think of it as hard.
Okay.
And then after I graduated, I was like, what am I going to do? Am I still going to do this med school thing? Or am I going to try to get into bioethics? And took a bunch more philosophy and ethics courses and took a course in healthcare ethics. And the teacher at the time was a social worker. And social worker turned bioethicist and built up the courage to say, I think I like this. I think I like the case base. I think I like the concept of interacting with people. Can I do this? I want to do ethics. And he said, go to social work school first. Okay. Become a social worker, do social work for a few years, and then do your MHSC in bioethics. So I was like, okay, sure.
Solved all the problems.
That sounds not easy,
yeah.
But did it. It worked out really well. And my plan was to work for about 3 years and probably around the 3-year mark, I was like, oh, I'm really liking this. Found my footing, had worked in a couple of departments, felt like I was finding my footing, was in a place in life that I was starting to feel financially secure, got my vacation days and can actually go away on vacation and not think about work. And I was like, why would I ever go back to school? Right. And one day my mom sat me down and was like, it's time. Yeah. It's the way that you're thinking about and talking about work. I think you need to take this next step. And the same kind of no, but I kind of like him financially. I'm in a good place. Right. And she's like, no, I think you should. And she was right. Okay. So ethics led me to social work.
Right.
Social work led me to ethics.
Gotcha.
And then doing ethics for a while led me back to social work.
Wow.
And now they're just, I don't see them as so separate anymore, because like my approach to thinking about social work is ethically informed. Like it takes on an ethics lens. But even when I was doing ethics, it was like from a lens of social work, right?
Yeah.
So they're both infused with each other for me now, that I can't seem to separate them out.
Yeah, so fair. So you started in social work because you knew you wanted to go the ethics, did that for a bit, then went back to social work, and now it's just all intertwined into one.
It feels like it to me.
That sounds awesome. Yeah.
Yeah.
It's like the best of both worlds.
I think so.
I kind of love it.
I hope so.
Yeah. So fair. And then the PhD, you kind of already said that was just the next thing based upon where you were at in your like career at that time.
Yeah, it was like this intersection of things related to both social work and ethics.
Right.
So when I was practicing social work, cannabis was not legal at the time.
Okay.
But conversations around legalization were starting to arise.
Okay.
And in practice, my last 5 years in social work was in NICU and pediatrics.
Okay.
And so we were thinking a lot about how do we navigate this. And so whereas perhaps the practice in women and children's spaces in social work before cannabis was legalized was you were consuming an illicit substance,
right.
Therefore we will call children's aid. So like the argument around calling children's aid was premised on it being an illicit substance. And, for really savvy social workers, it was like, and capacity to parent.
Right.
Right? But all of that kind of changed. And we saw that the change around our approach to this, how it was coming, and so started to have these discussions.
Okay.
And so went into ethics maybe a year before legalization happened. And I was presenting at a conference on like a framework for how healthcare providers should be thinking about cannabis consumption and moving away from this illicit, not illicit, consumption related to capacity to parent.
Fair.
And so like that kind of a thing, and starting to think about it more as, well, what are the intricacies? Like, what are the factors that play in this person's life? And really starting to take away from the concept of like baby as separate from parent and think about it as like a system altogether. And so less of a corresponding, parental harm to child, and more of a like what is happening in the whole system altogether. That we may not necessarily approach in terms of like, this is beneficial to the parent and this is how that benefits the child.
Right.
And was at this conference and presented on that. And one of my ethics teachers from years before had said, what are NICUs doing with breast milk of parents who consume cannabis? We're asking questions. We really don't know what to do. We don't know about like what will happen.
Right.
We know cannabis is lipophilic. We know that it is present in breast milk. But for premature babies or sick newborns, we don't actually know like what are the risks at play, and we're asking around. And it was like, oh, well, how are people even making decisions about what to do?
Right.
And so that was like the intersection of thinking about like the implications to social work practice, but then like a huge ethics question, right? We talk all the time about like the benefits of breast milk. We know what are the drawbacks about an inability or like not having enough breast milk.
Right.
We've moved to systems where there's like donated pasteurized human milk that are, provided to babies whose parents' milk supplies are insufficient. But if there is something that we deem as, impacting what in terms of a healthcare context or a medical model, what is regarded as like like impacting, or what may impact the health
Right.
of the child when feeding with the breast milk, and what is like the list of unknowns, and is the risk of the unknowns and feeding anyway, is there still some benefit?
Right.
And so there's like a huge ethical dimension to that as well. And then the project just kind of evolved from there when looking more deeply at cannabis and communities and all the rest of that. Anyway, yeah.
Right. So that's how that bridge happened pretty much from that
Yeah.
conference. Wow. So interesting. I know. I think it's so interesting to hear that, because same thing, like I did my undergrad, now I'm here, and like I've always teetered that, because I'm like, all of the interests you have, you kind of have to go that extra mile in your education if you want those questions answered.
Yeah.
But it's just the length, and then like you said, being in the work field and like making money and then going back. It's like, but it's so inspiring, and I think I just love how you were able to take all your interests and like at almost as you are working towards it, put it all into one through 3 different educational backgrounds.
That's so wild. It's weird. It's weird to hear it like that and think about it like that.
It's amazing.
Yeah.
It's amazing. That's
you.
very inspiring. Okay, so kind of to dive into it, I really want to get into like the history of social work. Such a bad rap in those times, because I feel like even if I were to think of it before I came into this like medical field, anytime I think of social work, you're kind of like, it was only present if there was like some type of crises happening. Or like child welfare. Like it just was like a scary thing, and you're like, oh gosh, no, not a social worker, something must be bad. That's how I thought of it, right? And it's like, I feel like that's like the stigma of where that like history rooted into it has kind of presented towards it. Now coming into my position now as a student to become a PA, and my best friend's actually a social worker. Oh my gosh, they're going to be my favorite person. You're my favorite person.
Yes.
Like, what can't you do?
Yes. I mean, lots, but yes.
So do you want to just kind of like dive into that a little bit of like maybe how that impact of the historical view of social workers has maybe played into some of like maybe barriers you face now, or how you've been able to like ensure or counteract any of those allegations? Like, how kind of has that history like dragged on, and what have you been able to do?
It's so complex. So the origins of social work in Canada is deeply rooted in like practices to support colonization. Right? So it was, rooted in, in many forms of eugenics in some respects. It was about the colonization of Indigenous people, right? Conforming to practices and standards that are rooted in white supremacy. And it was around immigrants, right? Setting standards, creating standards for newcomers to the country, people who were poor, people by any like classification other than cisgendered, white, middle class, anybody that fell outside of those classifications. It was like covered under the auspices of helping them. So we are helping them to get to that standard. And the help was wrapped in surveillance. We need to be able to identify you and keep track of you. But it was all sort of like under the auspices of like, we're helping you achieve this particular standard.
Right.
And the standard was unattainable. When we think about things like the 60s scoop, when we think about residential schools, the practices within residential schools, when we think about, even the processes of newcomers coming to the country and like, this is how you succeed in this place. And it was like conforming to standards of whiteness. Be careful of the food that you eat. Speak this particular way. Nobody understands you. You have to learn this. You have to dress like this. All of these things conform in particular ways, and social work is complicit in that. I mean, there's colonization is not just like on the backs of social workers,
right.
but it's the ways in which social workers contributed to these networks of systems to uphold this particular standard. That was incredibly harmful. Mm-hmm. I'm not even describing all of the deep history and all of the ways
right.
in which social workers sort of upheld that. But these practices continue to prevail in very different ways, right? So when we think about other systems that maybe not necessarily think about or prioritize or center like social justice as, their main function or their main value in the system or the sector in which they work, social workers still have to function within that.
Right.
I've worked in a hospital for almost 20 years. Mm-hmm. I have a great fondness towards the experiences that I've had while working in the hospital, and but I also have to reckon with the fact that I was complicit in many things
right.
as a social worker within a system. So certainly in, let's say discharge planning, really easy, really straightforward, right? This is like a kind of attention that social workers face where you can see the rush to get somebody with complex social needs out the door.
Right.
The social worker, understands implicitly, like, I'm supposed to advocate for for people in these situations,
right.
but your job is something different, right? And so you may be straddling the fence of like, I can go back to the team and say to the team, I don't know, we need more time. But you know that you have to respond to somebody in bed flow, somebody in patient flow, the manager, somebody who's saying, we don't have this space.
Right, and the cost.
And it will cost them. And your role then becomes doing this patchwork thing of, well, who do you have, right? So who else do you have? This is the universe of resources that we can offer you. You don't have the finances. These are the things that are OHIP subsidized. What else do you have? Who can you call on? And it puts it back on them. And it feels like this, to adhere so strongly to think about how to do a job well in healthcare as a social worker means a kind of aligning with those systems and structures. What I am saying, I'm not here to, certainly not here to comment on the way healthcare is delivered, and certainly not in acute healthcare spaces. But what I am here to say is that that's the reality. If you look at healthcare funding, that is just the reality of how things are. And how do professionals make things work within that system? And what is the role of social work in that? And the role of social work in that isn't necessarily looking at the structural pieces and advocating back to the hospital about we need to fix the structural pieces in order for this person to be well in the community.
Right.
It's a recognition that those structural pieces will never be fixed. So we have to do what we have to do.
Right.
And sometimes that means aligning with those kinds of limitations, those restrictions and those boundaries. And that can feel really hard when you're thinking that I need to come from a place of social justice.
Yeah. Yeah, I think just the way you said that, I feel like I kind of have an idea of why that this profession had that rap. Because at the end of the day, I think, like you were saying, you kind of had to be the face of being that bad guy, because it's this is what my role says. But then you're also balancing, like you said, justice for your patient. But there's so many barriers there with cost, system, infrastructure. So it's that hard place of how much can you advocate without knowing the system is at its limits. Yeah. But then you're letting your patient down. There's just so many things. So I think it's at the end of the day, your patient looked at you and were like, so you couldn't do it.
Yeah.
And like that's the rap that is, where in actuality it's like there's so many other factors behind the wall that played into that part, but you just had to be that person because you break the news, you walk in there, it's not the physician, it's not the nurse or someone like that. And it's like, I don't know if I've ever thought of it like that way. But that sounds bad, but it's like, whoa.
But I think also too, there's a way in which social workers are viewed as, can be, I shouldn't say are, maybe not currently, but can be viewed as agents of a system that is hard on them, right? So doctors are telling you that you need to like be discharged. You know, nurses are like, here's your medication, you got to go. And then in comes the social worker and you're like, that person's going to tell me the same thing. Anyway, they work for, like, there were times that somebody would say, you work for the government, can't you just get me money? And I'm like, I don't work for the government.
Right.
I don't have like the kinds of connections that you're conceiving of to be able to pull the strings that you need, that I know that you need, you know that you need. That's just not the function, but they see us as agents of something else.
Right.
And when social work on a mainstream is tied so closely to child welfare, we are perceived as like the groups of people. Like I worked in geriatrics for a couple of years. And, you know, we did things like provide emotional support, connected to resources, like helping people through really hard times and their caregivers around like new diagnoses of cognitive impairments or limitations, transitioning from like independent living to assisted living or into a long-term care facility, and looking at the, you know, material but emotional components of that and being able to try to be that support and journey with people. And I will never forget, to this day, I will never forget. Called somebody once, got a referral because it was like a new diagnosis, helping them plan and anticipate the next steps. Called their caregiver and they're like, are you going to take my parent away from me? And I was like, no. Yeah. No, I can't do that. Right. I don't want to do that. Yeah. Right? But that because of the association between social work and child welfare and apprehensions, that was the rap that I was given, even working well outside of women and children. It
was like the ideation that they had just going into the conversation. Yeah.
Absolutely.
Right. And that's what I mean by like that whole history thing. And again, before I even stepped into anything in medicine, like I myself too, like, I don't know, I feel like growing up you always heard of that, and like, oh, if something happens, you're going to be taken away, and it's always the social worker, like you always hear of that. Yeah. I think this is a perfect segue, especially for anyone listening who has dealt with the social worker or has not, to segue into like what, like the other avenues of what social work can actually do, and like all of the different environments, because you gave me that lecture about this, and that's where I sat there and I'm like, whoa, I didn't even know all those different aspects, like both in a hospital and out of hospital, where you can work and the like roles you can do. Like I think that example of geriatrics was a perfect example of like the things you can do that I think if you said that out loud to someone else, they wouldn't have expected a social worker to do that. You know what I mean? So do you want to dive a little into that kind of like outside of the basic scope of like where else you can practice and like kind of the role you can hold in those environments?
Oh my goodness.
I know there's a lot.
There's a lot. I'm like,
you can give us like the Coles notes a little bit. Loaded question.
Yeah. So I think about it in terms of sectors, right? Okay. Housing and homelessness, mental health and addictions, healthcare, schools, school boards, financial supports and services. I think about counseling. I think about newcomers. I think about like community development and organizing. I think about corrections, long-term care, assisted living, healthcare.
It's like every aspect, pretty much.
I think so.
Right? Like everything you've labeled so far has been from like every age group, regardless of where you're at in your life, whether you're in a profession, whether you're not in a profession, like depending on where you're at, like socioeconomically, you seem like you play a role in almost all aspects, or can lend some type of help in almost all aspects of life.
Yeah. And also recognizing that they're not sort of siloed.
Right.
That they are interconnected very deeply. Right? In a multitude of ways. That a social worker in a school may be concerned that, or a teacher in a school may be concerned of absenteeism for a particular child and contacts the social worker in an effort to help them, and not only from like, help us find out what's going on in the home perspective, but also how does this impact, like, how do we think about their learning? But then it might be the case that the child is being diagnosed or has an exacerbation of a chronic condition for which they require long-term hospitalization.
Okay.
So then the health piece comes to bear.
And would you follow that family or patient throughout all of that?
That's a great question. I would connect with my colleagues.
Okay.
Yeah.
Okay.
Because they would be, so like if I was a social worker in the hospital, I would think about the social worker in the school, and I would connect with them, because they would then be able to have a better sense as to like what are the resources within the school. They could better coordinate with, administration or the teaching staff to be able to say, here's how we make sure that that person doesn't fall behind. But also I would be connected to the team that has the knowledge to be able to say they're actually like not able to be able to focus on that. From a health perspective, we're more concerned about their ability, like their wellness and recovery, and the way that their diagnosis is impacting them at this point in time. We actually don't think that they have the capacity to learn, the energy to learn. They are in a state where they need to focus on this first. And I would be able to, like, what kind of supporting documentation do you need for the school to be able to record that this is not, a kind of absenteeism that is, that demonstrates that the child or the parent is disinterested.
Right. I
will be the person to facilitate with the medical team, like, the school needs a letter.
Right.
And here's how we do this. Yeah.
Okay, see, I never even thought of that either, because I guess I thought of it more like siloed, more sectioned off, but I think it's so important for anyone listening to understand that, like, you might specialize in one factor, but you'll be able to guide throughout the rest, knowing you have different colleagues. I think that's the beauty of it too. Like, as a physician assistant, like, you are a generalist, but then you subspecialize, and you can change. There's so much lateral mobility, and it's that same idea that I can help. You're still my patient at the end of the day, but the minute it moves to another specialty, that will move on, and I have a colleague in that as well. Yeah. So I think that's so cool too, because again, clearly I don't know enough about social work, but I think it's so interesting hearing about that.
The other thing that I will say, and I think about this as well, so it's not necessarily sort of like connecting with colleagues, but I think about this particular case. Often a child came in and was admitted with asthma exacerbation. Okay. And was sick, right? So when we think about, or at the time, admittedly, this was probably a little bit more than 10 years ago. At the time when we think about a length of stay for asthma exacerbation, we're thinking of somewhere around 2-3 days, depending on the severity, right? And one of the parents was in with the child, which we expected. But all of the child's, that child's siblings were in as well. And the staff was concerned, what's going on? Shouldn't the kids be in school? They need to be in school. This is going to be longer than a 3-day length of stay. That's a lot of school to miss. Can you find out what's going on? And then when the pharmacist was talking, doing a medication, oh my gosh, what's the term? Medication history.
Past medical history?
Yeah,
their records, a meds list?
Yes, meds list. So when they were reviewing their meds list, it was they discovered that actually what was happening with the exacerbation was that they couldn't afford the medication. So part of what, I met with the parent and was very much what's going on? There's a way in which that could be perceived as, oh my goodness, you're going to call child welfare because they're kids that are out of school for a period of time and I'm not forcing them back into school. But I was help me understand what's going on. She certainly unpacked, I have to choose between medication and food for the kids. And it's really hard. We try to manage the potential for exacerbations in other ways. And, and we're doing our best. And the kids are really concerned about their sibling.
Right.
and they want to be here. They say that they're not necessarily feeling comfortable, like having to navigate home and school without me around.
Right.
And they just want to be here. Never call Children's Aid. Right. And there's so much else that was wrapped up in it, because she was like, I don't even know that I'm a good mother, and it was like bursting into tears. And the work that I did was like, okay, let's figure out how do we like get you the kinds of resources for the medication that you need. If that is still not enough and there's cutting into costs, what else can we do? Like, what are the other resources that I can give you to help alleviate the costs in other places so that you can allocate towards the medication? And then reassuring her, you're like, you're not sure that you are a good mom, but all the kids want to be here with you. They're all over each other in the bed. Like, this is what I see. And they all look happy and content. And like, I'm not concerned with their presentation. And I see you really struggling here. So providing that emotional support, right? So the role of social work is looking at all of those other pieces as well.
Yeah.
And letting her know if there's a letter that's needed to help support you so that you're not getting the concern from the school, let me know. Happy to write a letter. Happy to tell them to, like, give them my business card. Tell them to call me.
Yeah.
Yeah.
I think that's, again, another example of exactly how that mother, her kid's sick, automatically assumed, you're taking my kid away right away, right?
Yeah.
Like, isn't that thing that we have in our society around this role? And it's like, it's the polar opposite. You had so many things on your mind to be able to help get the story and how you can support the drawbacks that might be facing before that was even a thought of.
Yeah.
Okay. So I think that's like where I'm like, okay, like, I think, I don't know, again, becoming a PA, there's such a role clarity issue, so it's about being able to advocate, and I feel like that's, like, you're giving such great examples of how you've had to be like, whoa, I'm here to actually help you in so many other ways, and it has nothing to do with that. So
yes, yeah, like, not like, let me put that off of, like, out of your mind.
You're doing like the complete opposite, actually. You're like, let me do everything to make this situation as best as we can make it.
Absolutely.
And stuff like that. Okay, so again, I don't even think in all of that we said what your PhD is even in. So I think the best would be talk about your PhD, maybe talk about your paper, and then I'll ask you those questions and stuff like that, because I feel like if I start describing, it might be like a little confusing. Like, what are we talking about here?
Yeah. Okay, so my PhD is at the intersection of Black maternal health, cannabis consumption, and infant feeding. So we talked a little bit about like the question that was asked of me by the time I started to think about doing a PhD. And so what I'll say is, in thinking very strictly about, well, how do healthcare providers make decisions where there's like a theoretical risk or versus like a material risk, and started looking into cannabis, it was like, oh, there's a discourse around cannabis. There's a lot of perceptions and feelings. And even that we are calling it cannabis today speaks about the discourse, right? So early 2000s and before then, like, cannabis was like a very medical term. We knew it, we understood it as a formal term, but, you know, weed, marijuana, like... Yeah,
there's so many other, like street names, if you will. Cannabis was always, like, medicinal purposes only.
Yeah.
Like, that's like, how it was thought about.
Yeah. And so, like, and cannabis, like, and when it, like, when there was the medicinal pathway, it was, like, medicinal marijuana. Right? And so the history and the context of cannabis prohibition and then legalization was wrapped up in many of the, you know, harmful eugenics discourses that were around, like, you know, wacky tobacco. That's the thing that makes people do bad things. And do you want those people close to you? Because your safety is compromised. And especially in the context of Black people and cannabis, and especially, like, there's a lot of research done around prohibition and sort of like the moving of goalposts with respect to laws and policies around cannabis in the U.S. and, you know, like, you know, the classification of cannabis as, you know, the same level as heroin, and, you know, all that, like the crack epidemic and how Black people were perceived, and all of these things there was this richness around, and my past experience, like looking at the differences about how Black parents, Black birthing people who reported cannabis consumption were treated very differently from white people who were consuming cannabis, or white birthing people who were consuming cannabis. And so like that was the intersection that came to bear, and like not necessarily from the healthcare provider perspective, but like we need to center the voices of people who have a particular experience in order to come to understand like what is happening epistemically, right? Like how does epistemic injustice, I'm going to use some technical terms for a second, but like epistemic injustice or testimonial injustice, somebody who's not believed as a speaker, somebody who's not believed in the testimony and the things that they say by the hearer, right? So like when we think about Black maternal care, and we're like tumbling, now we're like properly tumbling, but like when we think about Black maternal care and we use like Miranda Fricker is like the feminist philosopher who talks about testimonial injustice. She talks about it as like a credibility deficit that is afforded to the speaker on the part of the hearer, and there's power in that, right? So the hearer gets to determine whether or not the speaker is credible, and then makes determinations about like what to do next based on what it is that they say. But the hearer draws on what Fricker calls the collective social imagination. So all of the stuff, all of the discourses, all of the things that we come to understand and know, and just assume or know to be true in one particular way or another, that then filters out, that person, like, I should, like, yes, they are, like, I would believe what it is that they're saying, or like, who knows? I don't know that I know, like, I believe what it is that they're saying.
Yeah.
Prime example. Somebody comes in, do you smoke? Yes, how much do you smoke? 3 packs a day, and multiply that by 3. Right?
Yeah.
So that, in that instance, that person, the hearer, is affording a credibility deficit to the speaker.
Okay.
Right?
Yeah.
And so that's kind of how that works, right? So in the context of Black maternal care, there's this notion, and I've like totally switched now. Like we've shifted away from like Black people who consume cannabis. Now we're on to like the notion of like Black maternal care and the troubles with Black maternal care through the lens of testimonial injustice is that, you know, mainstream discourse obviously is that, you know, Black women don't trust their healthcare providers. Right? But if we look at it through the testimonial injustice lens, it's healthcare providers don't necessarily trust what Black women are reporting.
Correct.
Prime example, Serena Williams, right? Long history. We all knew before she was pregnant with Olympia that she had pulmonary embolisms, and she was being treated for pulmonary embolisms. And she knew what she was experiencing in her body and said, I think this is a PE. And if it is, this is what I need. Right. This is what I need. I need this medication. I need this treatment. And the nurses had said to her, no, that this is your body responding to the anesthetic that you received yesterday.
I don't get that. Like, how come, and again, I don't want to speak from terms of anything, but like, how come some patients' health literacy is like not taken seriously?
Yeah.
Like, is it that power dynamic?
There's a kind of,
because in my head, like, again, I'm a student, so take everything I say with a grain of salt because I have so much learning to do. But like I've always said, my biggest thing is I want my patients to have the highest health literacy, just meaning for anyone who doesn't really understand that, just like I want my patients to fully be able to understand in their terms what their diagnosis is, what medication they're taking. Because that's like scary. Like, as a patient going into the doctor's office, them saying a bunch of stuff, giving medication you take, and you're just like, what just happened? What am I taking? Yeah. Like, my biggest thing as a future like provider is I want to make sure health literacy in my patients is so important. So I want my patient to come into that room and be like, no. Like, this is what I have. I know this is a symptom. This is what's going on. So in my head, I'm just like, why is that not taken upon? In the perfect world, obviously. Like, I know there's the flip coin of it where that is maybe taken advantage of in a patient's perspective at sometimes too. So like there's two sides to every story. But for example, in that Serena Williams example, I'm like, how?
Yeah.
Like why?
Yeah. So like in my mind, it goes to two different things.
Yeah.
One is, and I mean this with, like I'm saying, I hear, let me qualify my statements, what I'm about to say next. I hear and I know what I'm about to say next can be really challenging for people in healthcare systems to take up or to hear. There's a kind of epistemic privileging that happens in healthcare.
Right.
It is inherent in the power dynamics.
Of course.
Right? We say all the time, like, doctors will say, I went through training. I've been practicing for X number of years. I know this. And I'm telling you, this is what it is. Or I'm telling you, that is what it's not. Right?
Right.
And that's not necessarily wrong. So I want to be clear. There's no value, good or bad, that I'm putting to this. It is a thing that happens. And there, like, that kind of epistemic privileging, I think, is what happened to Serena Williams, right?
Yeah.
Which is like, people get anxious. This is your first child. You're probably anxious. And, you know, perhaps one of the side effects of the anesthetic that you received makes you feel this particular way. Just go in your room and rest.
Right.
Right? I can see a way in which that happens.
Yeah. I don't want to sound like I'm speaking from the most facts, because I agree. There's like, when I say something like that, it's like in the most perfect world.
No,
yeah, like it's in that center where I'm like, but how? But why?
No,
of course. And
then, like, healthcare has a particular kind of language, right?
Yes.
Like, I don't know if you've had this experience yet, but like, if you've had to go into, let's say, a hospital, whether for yourself or for your loved one, or seek medical attention, and you're like, there are things like, somebody's like, what are your symptoms?
Oh yeah, like I could tell you exactly what you're going to ask me. I have the answers to the questions you're about to ask me in my head.
Yeah.
Because I have that training.
Yeah.
Is that what you mean?
Yeah.
Yeah,
and I'm going to say it in a way that we both understand.
Right.
Because it gets to the point, it's the quickest thing, and you're going to know that I have a particular kind of health literacy.
Right.
So that, like, let's do this.
Yeah.
Right? Mm-hmm. And I think when we think about health literacy, we learn it as people working in healthcare spaces. Right. We learn it because we are immersed in it. Mm-hmm. And for people who, you know, interact in healthcare systems quite a bit, they come to learn it to a certain degree.
Right.
But we understand, you're like, they may not have worked in healthcare, but they have been in healthcare spaces quite a bit because they're communicating in a particular way, versus somebody who's like, what seems to be the problem today? You know, like, emesis times 3, you know, like.
Yeah, it's like anytime you see, maybe like in a clinic I used to volunteer in, anytime you see like an elderly patient, the person around them, I'd say like 70% was like, oh, don't worry, I'm a paramedic, I'm bringing my nanny in. Oh, actually, I'm a nurse, I'm bringing my nanny in. And then it was automatic, like, okay, cool, I can't wait to communicate this way and you're going to understand it. But if that paramedic or nurse wasn't there and it was just the nanny, how does that look?
How does that
look?
And
is that person walking out like,
yeah,
I have no clue what just happened?
Yeah. But also, there is a kind of like, there's a kind of way of thinking about one's own physiological symptoms.
Yes, of course.
That, like, somebody's like, what seems to be the problem? And you're trying to articulate it to them in the best way you know how, but it doesn't fit quite nicely or neatly into the, like, medical terms or categories.
Right.
It becomes really hard. Mm-hmm. That wasn't Serena Williams' case. She was speaking the language.
Right.
Right?
Yeah.
So there's, like, for me, I think there's two things happening. And, like, teaching health literacy, you know, sort of balances it out, right?
Yeah.
Like, it gives patients power in a particular way. It doesn't absolve them of everything.
Yeah.
Because when we think
Very
about the
good point.
collective social imagination,
Yeah.
according to Miranda Fricker, we think about all of the assumptions. So imagine that you are teaching health literacy to a patient that you have come to know for a very long time, but they are unkempt.
Yeah.
That they are soft-spoken, that they speak with an accent.
That's
right?
a very good point.
They take a long time to respond.
And how's that can be perceived to the next provider.
And that's right.
Yeah.
They show up to the emerge.
Yep.
And they're like, what's your medication? I only take this and this. Well, we need a list. Because the trust is now breached.
Right.
Right?
Yeah, so fair.
Yeah.
I've never even thought of it like that.
Yeah.
Very good point. So it's like health literacy can only go so far because unfortunately there's barriers, both physically, like right off the bat, someone walks in and there's already a barrier depending on what they look like or how they sound.
Yeah.
Ugh.
Yeah. And so that happens in like Black maternal care in different ways, right? So when we think about the history of like reproductive care on Black bodies, we need to go all the way back, right? So when we think about and talk about like what we understand present day, and we think about social determinants of health, or we think about clinical diagnosis, acuity at delivery, and any other sort of procedures that needed to be done, right? So, for example, history of diabetes and hypertension, preeclampsia in pregnancy, cesarean section, postpartum hemorrhage, baby to NICU.
Right.
Right? And then we look at those statistics, or we look at those bits of information, and we say, yes, of course, this Black woman has a history of hypertension and diabetes because Black people just have higher, incidence or prevalence of diabetes and hypertension, and we can point it back to the kinds of foods that they eat.
Right.
That's one set of classification. But the other thing is thinking about racism, right? So we're talking about like the difference between like distinguishing, factors or conditions between races. And now we're talking about racism.
Yeah.
And when we're talking about racism, we're talking about things like Black women have a higher threshold for pain.
Right.
Right?
Mm-hmm.
And it appears to be, well, isn't that like a kind of a centering of care? Or isn't that like, doesn't that consider race in a particular way that we should be thinking about when we're thinking about equity in healthcare? And the answer to that is no. Mm-hmm. Because in the history of gynecology, when we think back to the history of gynecology and the grandfathers of gynecology, it was all premised around the abolition of the transatlantic slave trade.
Right.
And so Black reproductive bodies were used to perpetuate, to continue to bring children into, contribute to the labor force of slavery because they weren't transporting bodies.
Right.
And so what that meant, and if you think about the Black body generally as property at that time, and Black reproductive bodies as important to continuing the cycle of labor, then you have to look at ways for preserving their reproductive integrity, right?
Yeah.
And the grandfathers of gynecology themselves would say, we could never do this on white bodies.
Right.
Right? Those white bodies do not have the fortitude to withstand this. And so we will do that. And it was things like over medication, under medication. And we're talking about, also wrapped up in that, if we're thinking about Black bodies as property, then they're not getting consent from the person themselves. They're getting consent from plantation owners.
Yeah.
Right?
Yeah.
So there isn't a kind of engagement that happens there. There isn't a consideration for, well, how does that feel? That body becomes a function, an object. Right? And so if we think about what we understand as present day practices that's rooted in these foundational pieces, and that are just like, well, that's like either race neutral, or that really considers like, well, that is like, isn't that what equity is supposed to be? It's not, because it is premised on this idea of like Black reproductive bodies as non-persons and the things that one can do to them.
Yeah, I think you bring up so many points that I actually highlighted. So you had this amazing commentary paper that literally I love. It's called We Bawl So We Are Heard, The Stories We Must Tell, Obstetric Racism. I think the first thing, just to like kind of summarize slightly, the paper as a whole is a story in itself.
Yeah.
You start like kind of opening up in this like beautiful like familial setting, telling this story, and then you kind of transition right into like some hard facts backed up with examples, proof, and then you transition back into the ending of the story. And I think what I really like about this too is exactly what you said, like the stories we must tell about obstetric racism, because I think sometimes if there was just a paper that came out but then didn't give some type of perspective, people would quickly scan it and go to the side. Whereas this, it is truly a story. Even if you don't understand anything about med or anything like that, you can read this and you can learn. And that's what I really liked about this paper. So wanted to just say that because I really, really liked it. And I think you were just talking, you brought into that point about kind of, it almost sounds as if Black women at the time were like test subjects.
Yeah.
Like they're like you were saying, like, oh, they would never do that on a white woman.
Yeah.
It's like it's like labeled as a test subject.
Yeah.
And it's like, and I think also, I think you brought up a good point too, is when people are like, but how does this happen? Because, you know, you always think, oh, that was our history. Yeah. And I think that's the issue as a whole, is like, that was our history in a way, as that was our foundation. Yeah. That doesn't mean it's not happening in present time. Yeah. Because we started and we're rooted in that, that's what we've continued to grow up, and it's what it continues to happen. Yeah, of course there's movements and there's things we're trying to do, but because that's our foundation, that's that ideation, like Serena Williams, that's that thing that unfortunately our foundation started with, that's continuing to persist. Yeah. And again, like in that part, like that's where I really sat there, and it's like, it's just crazy to hear that it's literally these women were treated as like test subjects. Yeah. Like it sounds like an experiment.
Yeah, they were.
Couldn't go in, you couldn't tell you what your feelings, you had no say, no nothing. Yeah. This was done to you, and then next.
Yeah. And for the preservation of reproductive integrity. Right. Right?
For their use like again.
Yeah. So it wasn't about like are you feeling better? It was like, let's see if you can have another child. Right. Let's see if the structures are intact so that you can go on to have more children. Yeah. Yeah.
I don't know. Again. And I think a few points you just like you put in this point, there's a part that says Black women often described being disregarded by healthcare practitioners about their wisdom with respect to their own bodies. Exactly what we're talking about when we're talking about Serena Williams. And it's like that right there is a failure of the system. Yeah. And it's like each provider in that time, not only did you have to self-reflect in what you just wrongfully did, but then there's that system in the background that also, whether it was your training, whether it was your schooling, the way you were brought up, the environments you were brought up in, all of that, again, rooted in our societal like history and that foundation we've brought up on continuing. So I think that's like my biggest pet peeve when we talk about certain things, is like saying like, oh, well, that was our history. Yeah. But it's not.
It still exists, right?
Like that's present day.
It's present day. So there was a study done, or there was a report published in 2020, and they continue to be published around Black people, Black birthing people, Black mothers, Black women who are like, I feel distress because I am not heard. Mm-hmm. I am telling people what it is that I need, my healthcare providers. And this is a very difficult thing that's happening. I have to have a lot of trust in you in order to go through this, and I feel like you're not hearing me. Right. And it becomes super challenging, super interesting, because these are sort of the like vestiges of not having a voice in the past, and then not being afforded credibility in this current state, in this present state. And it's so incredibly challenging.
Right. Yeah. And I think that's the whole point too, like the title of like, we have to bawl, or we have to bawl to be heard. And it's that idea of like, that is what those women were like taught when it came anything around maternally, on how to at some point or at some degree be heard.
Yeah. So this like, it's interesting because that story actually, like those are real stories that happened back in 2010 that I didn't piece together until doing this, like doing my PhD. And the thing about bawling is that the fear of like going back to this notion of the collective social imagination is that Black women are regarded as aggressive, as loud, as, all of these things. And so to counterbalance that, to be seen as somebody worth listening to, there's like, there's a theory called obstetric racism that goes into this about all of the other things that Black people or Black women do in order to be afforded credibility. And talking about bawling, it's like resisting that thing that you've been taught, which is like, be quiet, be kind, be nice, be gentle, so that nobody will have an opportunity to call you aggressive. And if they're not listening to you, you have to bawl.
Right.
You have to be loud. And just noting also that intergenerationally, this is a mechanism for survival among Black women, right?
Yeah.
Because if you get loud enough, somebody has to respond.
Right.
And never mind that, don't be loud so that you're not labeled. Be loud so that they attend to you.
Right. And I think that's what's important is in the beginning of the paper, it's literally set in the scene of you like just telling stories. And like that's that whole point of Generation, that it was just a story. And then in the end, it kind of happened. And it was just like, that's where I really loved the format, because it's like you started with just storytelling, then you hit, which I love, with like the hard facts, the proof, everything in there, and then you finish with the outcome of an unfortunate story. Yeah. And it's like, oh, I love this paper. Again, it is We Ball, so we are heard, the stories we must tell about obstetric racism. And I think just to kind of tie in and finish the episode, Black Maternal Health Week just kind of passed us. I know I was trying to time our episode around it. It just didn't work. But I think my one question that, again, will help a lot with what your PhD is doing, I think it's so interesting when you look at the data and research we have in Canada. And we don't collect, because a lot of the things data I was looking to, race-based data, we tend to turn to the US and use that. And again, kind of a loaded question, but why do you think that's a thing in Canada?
Yeah, that's a great question. I think there's a long history, and I'm thinking too about like research ethics.
Right.
I think there's a long history of a fear of like identifying oneself as a marginalized part of a marginalized community because of the risk of what may happen. That when you think about doing research, it's like, do you actually need that question, or do you need that identifier in order to answer your question? Because that may highlight something about somebody that may put them in an unduly vulnerable position. And I think that we're just, there's this fear of overcoming that, right? But there are like lots of there's lots of annual conferences, and there's lots of annual gatherings and advocacy around collecting race-based data. And I think communities, and not just Black communities, are like, we want to know how this is impacting us.
Right.
And so there might be a shift generationally that's happening that, I kind of feel like I'm in the middle of, where when I was applying to undergrad, like, what's your race? And I remember being told, like, do not ever share that information because you don't know what they're going to do with your application as a result of that. And thinking about younger generations that are like, oh no, I want to be able to have information that speaks directly to me.
Yeah.
And people like me, like racially like me. And so I think there's a tension there, and there's a lot of people, Dr. Anya Norum, who's like leading a lot of the push around collecting race-based data. And the Better Outcomes Registry and Network, BORN, I hope I got that acronym right, but BORN, they are trying to do their best with respect to getting information and data around maternal child care and health that is rooted in, like, that tells us information about race. So they're doing a lot of that and trying to sort of triangulate the information that they have in ways that can be helpful and meaningful and thoughtful about care.
Yeah, so it just sounds like, I guess there was a lot of barriers to it, and not necessarily one person just like kind of taking that jump. So everyone was just kind of like stand back. And then eventually, like you said, the more one person does it, it's going to happen. we're just behind.
And trust.
Yeah.
Right? Building trust.
Which
building
is
trust that's like
hard.
Yeah, like building trust that's like you're not going to take advantage of my information.
Right, because that's already the mistrust they have in the medical system and so many other things. So it's like, how can we overcome that for you to then be put in potentially a vulnerable position so that we can inherently potentially help you in the end by getting this research out there. But it's like walk someone through that. Like,
and there's long histories of, vulnerabilities and kind of taking advantage of Black and Indigenous communities in the realm of research,
right.
and that has been attempted to responded to in research ethics, but like you can respond to them with like regulations and policies and guidelines and all the rest of that, but it's about building the trust in the community, right? Henrietta Lacks, the Tuskegee experiments around syphilis, and like all of these kinds of things, right?
Again, those are like those deep wounds that were hit in our foundation that, again, why would anyone then want to? Like, what's in it for them at that point without worrying about what, again, like you said, mistrust or information? Like, I can't say I understand, but I can see why. Like, I can see how that's hard. And again, like I said, I think a lot of it has built around our foundation that I agree. I think I'm probably in that time frame of where I grew up, where it was like all these movements, and now we're finally trying to make impacts. And now, especially in admissions, now it's about like everyone. It's not about like, like you were saying, like that is scary to have to be told, like, don't say, like, don't let them know that. Whereas now it's like, we want around the world, we want every color, we want everything,
and we want this information to be transparent so that we know, like, and we can respond to it.
Because then that feels so much more like that's truly how everyone's voice is then going to be felt heard. Because if we don't have that research out there, of course there's this whole community that is like, but what about me though? Same thing, like you're saying in this Black maternal health, like there's so much out there that goes so unknown that, again, I agree. I think we're doing a better job, but we still have so much to do. So much to do. Well, this has been great. I feel like we've been on so much tangents, but it's been awesome. Thank you so much.
Thank you.
I think you've definitely, like, my ending is always like, what as myself being a PA or any other allied healthcare can we do better about utilizing you? And I think you've shared so much about understanding maybe the more clarity of the role and the diversity of the role.
Yeah, and appreciating, like, we're seeing people with more health and social complexities appearing in healthcare spaces, and appreciating that, yes, there are things that medicine can do.
Yes.
But when we think about the their longevity and their wellness, it requires like a bunch of different things. So think about the role of social work as coming together, bringing together, looking at people holistically and recognizing what are all the pieces that we can contribute to and work as a team to make sure that they have what they need when they're back out in the community. Exactly,
because I think maybe if someone wasn't properly utilizing that role, I think it's understanding, like, when that person steps into an ED, something happened that got them into that. Housing, nutrition, medication, cost. There's so many aspects that play a role in why they're there. And it's like, agreed, medicine can help them in that very moment, but right when they go back to it, there's so many other factors that need to be looked at and need to be held. And I think you've painted such a great picture of so many ways in which you can lend a helping hand, whether it goes beyond your role or your ability, but you have a resource. There's someone else you can turn to. And I think that's what's so important in healthcare, being able to work in a team and realize where your expertise is halted, and when you can then push to that person and move to a social worker and say, like, this is what's happening. I need your help, and I know there's something. And if not, we can turn to the next person, and so on and so forth. Yeah. Well, thanks so much again. I really appreciate you. I think you shared a great perspective, not only on like the social worker's lens, but being able to speak so much on Black maternal health and the importance of the PhD and all your work you're doing right now. So again, thank you so much.
Thank you.
This is the PA Perspective Podcast. Again, my name is Mackenzie. I'm your host, and we are breaking down barriers in medicine, one voice at a time.
Thank you.
Thank you so much.